Right, it's 2:30, so I think we'll start the webinar. It's just after 2:30. Welcome to the Men's Health Forum Men and COVID-19 webinar. The theme of today, new lessons learned and the challenge of inequality. I suspect some of you may have been here for the earlier webinar we had back in April. So a lot has happened since then, and that's what we hope to cover during the course of today's presentation. So first of all, thank you for coming. It is being recorded and will be uploaded to YouTube, and we will also circulate the slides by email as well. Feel free to introduce yourself in the chat. We do also have a Q&A function, which we found quite useful at the last meeting, so feel free to use that as well. And you can ask questions by typing as the meeting goes on, and at an appropriate moment, we'll address them either during the course of each individual presentation or at the end. So, first of all, let me introduce the charity. So the Men's Health Forum is a charity. It's been around since 1994. We were set up by the Royal College of Nursing. We became a charity in 2001. We've worked closely with the Department of Health and then the Department of Health and Social Care since 2009. And our mission is simple. It's to improve the health of men and boys. We do that in a range of ways, but the ones we're probably best known for are the health information for men that we do with our man manuals, but also toolbox talks and through our website, and also sharing latest insight and research for people and practitioners, and working for policy change and for men's health issues to be given greater priority. This is the outline of today. I'm Martin Todd. I'm the Chief Executive of the Men's Health Forum, and I will do a brief introduction and a quick overview of the current situation as far as men and COVID-19 is concerned. Then Professor Alan White, our patron, Emeritus Professor of Men's Health at the University of Leeds Beckett, will talk us through some of the lessons learned since the last webinar, but also making sure there's, for those who weren't at the last webinar, we'll give a slightly wider overview than that. Peter Baker, former Chief Executive of the Men's Health Forum and Associate of the Men's Health Forum, but here today in his role as Chief Executive, as Director of the Global Action on Men's Health, which is the sort of global equivalent of the Men's Health Forum, who are launching a very important policy paper this week, which we'll refer back to. And finally, Professor Gurch Randhawa, who from University of Bedfordshire, and also a trustee of the Race Equality Foundation, but I'll talk a bit more, who will be talking about challenging inequalities. And then hopefully there'll be room for a discussion at the end for us all to join in on. So let me start then by going through the current situation. Now, you may recognize some of these slides before, but we've tried to bring all the numbers up to date. And on some of them, there are actually some quite important changes that have emerged. And on some of them, there are numbers that we weren't able to show you last time. So starting with this one, which gives a picture of quite how overrepresented men are in critical care. So this is a report produced by a critical care charity, and analysing what's going on in critical care with COVID-19 admissions, with COVID-19. So men are 70% of admissions, and that compares to 54% for viral pneumonia in the last 3 years, 72% of people who go on for advanced respiratory support, only 68% of people discharged alive, and 74% of people who died in critical care. Very similar picture to last time 2 months ago. Sadly, the numbers sitting behind it are much higher. But one area that has changed versus last time is the overall picture. So these are the overall picture of deaths in England and Wales. And when we were talking about these in April, there were more men than women dying in every single age band. And what's happened now is that that's reversed with 85 plus, and men are now 55% of deaths. Now that's much lower than the number of people who are dying in intensive care, and a big part of that, we suspect, is the increased number of deaths in care homes, where the people there are mostly women and older women. So that reflects the lower proportion overall, shows what is now known as to what happened in care homes. It's a similar picture in Scotland, where actually slightly fewer men than women have died from COVID-19. Again, a similar picture where men are much more highly represented in every age group until you hit the oldest age group, where there are many more women dying from COVID-19. One of the areas that's been very interesting and helpful in the last 2 months has been a great deal of information's come out about health inequalities. This was something that we were pushing for very hard. We were pushing to get more gendered data across the board. ONS has actually been very good at this, and probably the best of all the national bodies that have been reporting, and produced some very striking data on male death rates. And what it showed is a very steep gradient between people in professional occupations and people in low-skilled professions. And then you can see that some jobs in particular are dramatically overrepresented. So security guards, taxi drivers and chauffeurs, chefs, bus and coach drivers and social care workers. So some of the jobs that men are doing in particular, hugely overrepresented in terms of male death rates. So as we see in all kinds of areas of men's health, such as suicide, for example, what we're seeing here is that there are big inequalities according to the jobs that people do. And as you can see in the next slide, according to the areas that people live in, and this is the age standardized mortality rate by deprivation decile. So it moves, but the higher figure is the ratio of people dying, likelihood to die in a particular deprivation area. And you can see again, it's more than twice as high, both for men and for women, as you move from the least deprived to the most deprived area, the death rate more than doubles. And certainly a woman, in the 2 or 3 most deprived areas is more likely to die than men in the richest areas. So a very important factor that again was not clear when we met 2 months ago. And then something that has had rightly a great deal of attention, and these are the figures just focusing on men, which is the extra risk of dying from COVID-19 amongst different groups of men from different ethnicities. And again, what you can see here is that all other things being equal, a black man has 4 times the increased risk of dying compared to a white man. And that's all in the context of, as a man, being twice as likely to die anyway. Very quickly, some information on testing. We showed this slide earlier, which shows hospital testing. And what it shows is amongst older men, older people, the majority of people being tested are men. And because this testing also includes health workers, further down, what you tend to see is that most of the people being tested are women. So no real surprise there. What is a surprise and is a bit concerning is this is the testing rate out of hospital. And what you can see here is that the test rate amongst women is much higher than it is amongst men, even though we know that the outcomes for men are much worse. And so there's a question there as to how effectively men are being encouraged to get testing, or whether that message is getting through to them. I wasn't expecting that slide to be there. This is hospital admissions by age group, again showing the bias towards men. And a last one, and again, which highlights a possible issue. There has now been a very basic equalities analysis done of the shielding list of people who are clinically extremely vulnerable. But it doesn't cover an awful lot of factors. So it doesn't cover ethnicity, for example. The one thing it does cover is gender. And even though we know that men are at much greater risk from COVID-19, men are the minority of the people on the shielding list, which does raise the question as to whether the right people were on that list. And you can see that men are, no surprise, more likely to die, but less likely to be on the shielding list. But one final observation: there is definitely the case that policy is now, there is recognition, at least, sort of on the record from national inequalities analysis, that there is an issue with men. So this is the recent equalities analysis that you heard a lot about. Rightly, it has drawn a lot of attention to the issues that relate to minority ethnic communities, but it does also, for the first time, make a really clear statement and recognition that there is a much elevated risk, particularly for working age men, where it's twice the rate of death rates compared to women in working age, 1.5 times overall. So that's a quick update on where we are. The next speaker is Professor Alan White, patron of the Men's Health Forum, and he's going to take us through some of the lessons that we've learned over the last 2 months.
Thank you very much, and welcome all. This has been a most incredibly intense time for everybody, and not least for research. It's quite remarkable. If you put COVID-19 into PubMed, for it would only have been articles that have been written since December, really. We've now got 23,473 papers, academic papers of all different sorts and sizes. That's excluding all the papers in Cyclit and all the other databases. So this is just in relation to medicine and health. And so it just shows that trying to keep up with this is almost impossible. Can you go on slide, please? I just want to say at this point that we've been working very closely with women's health groups, because this is a significantly impactful disease on women and girls as well as on men. And so no matter what we say today in relation to men, I think it's very important that we rightly recognize the massive impact this is having on women and girls across the world in all sorts of sectors. We could easily have a talk on the challenges that they're facing as well. Could I have the next slide, please? Right, risk factors. Well, we knew older age, and actually an interesting report that's just come out from Clark et al. The reference has disappeared off the bottom of the screen, I apologize, where they estimated that 6% of the male population globally at high risk of hospitalization due to the amount of non-communicable diseases that men have. And actually, if you look at men over 70 years, 26% are at risk of requiring hospitalization. So being a male is a factor. Being an older male is significantly more factor. And as soon as you layer on top all the intersectional factors and social determinants, it becomes even more apparent the challenges we're facing. Chronic health conditions are also, we knew that before. Every time we're now getting data out from the different centers around the world, we're seeing that chronic disease features time and time again. Chronic heart disease, hypertension, heart failure, diabetes, chronic lung problems, asthma. And apart from for asthma, nearly all the non-communicable diseases which are impactful in relation to COVID, we know are more heavily prevalent within the male population. And that feeds back into smoking, alcohol, diet, obesity, and other factors. Obesity is seen as being a significant issue for men, and we know that more men are overweight. A very high proportion of obesity prevalent in men as well. When we start to look down below that at the biology, the leptin, chronic levels of leptin, the impact it has on inflammatory disease, but also the fact that a significant part of obesity is its prevalence within the poorer areas of our communities, where higher levels of virus are absorbed within the fat. It is more likely to last for longer, and we have actually to be really conscious of the implications of obesity in terms of how long people need to be convalescing for. Could I have the next slide, please? Biological factors, very important. Now, this is where we were before. We knew that ACE2 was significant. We probably didn't realize why it was significant. We know that ACE2 is a part of renin-angiotensin system, and it helps break down angiotensin 2 into angiotensin 1-7. Now, angiotensin 2 is a problem. Angiotensin 1-7 is a good thing. It's a pro-inflammatory, vasodilator, anti-inflammatory, enhances homeostasis. So when this virus gets into the body, and the main route in is through this ACE2 receptor on the cell wall. For men, we only have one form of ACE2. Women, because it's created on the X chromosome, it's on both, and we then have the depletion for the male form. Women have an excess, so therefore we're more likely to find that our ACE2 is being used up to get the virus in. And that has an implication because it lets loose angiotensin 2, and we know that that's got a big impact on inflammation, coagulability, vasoconstriction. So the biology of ACE2 is emerging all the time. It links in with endothelial dysfunction, which is already problematic in a lot of men because of issues in relation to obesity, diabetes, coagulopathy. We're thinking now that there may be a male sex angle to coagulopathy, cytokine involvement. We know that cytokines, we've got a greater level of interleukin cytokines, the spike proteins, which is how the virus binds. As I go on, the biology is complex, and it goes, because of it, you realize how widespread it is through the body. The sex differences in immunity, again, we're just reaffirming some of what we knew before in terms of the role of estrogen as being immunoprotective and testosterone being immunosuppressive. Testosterone is also emerging as a key factor, especially in deficient men where we've got pro-inflammatory cytokines more likely to be present as a consequence of a deficiency in testosterone, and it impacts on virus clearance in the testes. Can I have the next slide, please? Ethnicity and race has been so clearly shown by Martin. Why that may be the case, we think that a lot of it is in relation to where a lot of the Black and ethnic minority population live within poorer areas of the country. Linking in with some biology, we know that South Asian men have approximately more fat tissue, lower BMIs, where there may be an issue around ACE2 for hypertension risk. Higher risk of high BMI, higher risk of factors relating to overall comorbidity within the BAME community. And it also very strongly links to poverty. And we've seen through the data from Martin again, where time and time again we're seeing that the people most affected are people from the poorest parts of our society. And that impacts on crowding, it impacts on the kind of work that they're doing, and the ONS data on occupations really reinforces how a lot of the jobs that are available within the poorest area mean that they are not able to sit at home, do their work on full pay. They have to go out, they're in crowded housing, they're in crowded environments, they have to use public transport, and it just reinforces also how the main viral spread of this is through large droplet. It's in the close confined environments where a lot of people are living and working, where it's got maximum opportunity to spread. Access to health services is also a factor, as we've just seen in terms of the testing, and also willingness to put yourself forward to be tested. Next slide, please. Smoking, now this is a complicated one. We know that smoking increases the risk of lung disease, and we would have assumed that it would be impactful in terms of the risk. Most of the data at the moment seems to be suggesting it is not high on the list, and there's various hypotheses being put forward as to why that may be. Whether it's the fact that the lungs are already compromised and therefore the virus has more difficulty getting in. But we know that that is a very important and serious message that's going out, because we do not want people to increase smoking, because the consequences of that are massive in the long term. Alcohol, not so much in terms of developing it, but we've seen the spending on alcohol being tremendously elevated. Hand washing, denial of risk, links up with what we're seeing in a lot of young men. Delayed help seeking, perhaps, I still don't think that's a big issue, but we've got to get people out there to be tested. Working practice, cultural practice. Can we go on to the next slide, please? Now, emerging challenges. We've got 3,500 males have gone through intensive care. That is significant in terms of the experiences they've gone through, the PTSD, the neurological deficits. A lot of these people are very sick. We're going to have a lot of people coming through, male patients coming through, which are actually quite debilitated, require long-term rehabilitation. The misdiagnosis, the mistreatment, and the misscreening that's occurring because of the lockdown is tremendously impactful. Because of we're missing out on bowel cancer screening, we're missing out on people going with chest pain. And I think that the long-term consequences of what's happened there is going to be awful. And the mental health service disruption, talking to many colleagues in the statutory and third sector about the risks that are now being posed to people who normally have been supported through their mental health issues and just not getting that support. Could I have the next slide, please? And our lives, oh my goodness, the impact this has had on personal relationships, and the effect on inter-partner violence, what's been going on within that family, tight-knit family situation is going to emerge as the time goes on. Breakdowns, but also build-ups. We've got to be positive in the fact that some of this personal relationships may have come through extremely positively and built things up, but we're also seeing this huge number of people that are reporting intimate partner violence, and I think that is absolutely crucial. Fatherhood, great opportunity. Extended paternity leave for some, great opportunity. Other challenges, social isolation and loneliness. We've got a paper coming out on that next month. That is also going to be a factor that is going to impact on people's mental and emotional state. Bereavement and loss, the disruption to grieving. Now, we know that men sometimes struggle with grieving, and the fact that they've not been able to do what they expect to be able to do, and loss of loved ones, tremendously difficult. But we're also going to have to support lots of women as well who have lost their husbands, partners, because of this, and in gay relationships. And changing work patterns, how that's going to impact in the long term, but worklessness and recession. The suicides that have gone up over the years as a consequence of economic downturns is nothing compared to what we may be seeing over the coming years. And I just want to finally end on disrupted boyhood and education. We know that our boys miss out on a good education, especially boys from poorer environments. And I think that the whole experience of boyhood has been disrupted and impacted by this. And we must be careful about how we move forward with boys to support them as they go forward. Thank you very much.
Thank you very much indeed, Alan. That was extremely helpful. So there are a few questions, but I think we'll save them up towards the end. I'd now like to introduce Peter Baker, Director of Global Action on Men's Health, a good friend to the forum, and yeah, as it says on the screen, a call for policy action. Peter.
Thank you very much, and congratulations to the Men's Health Forum for organising this really important webinar today. I don't think you mentioned, Martin, that it's Men's Health Week this week, and I don't think there's anything more important that we could be talking about during Men's Health Week than this issue. It's very, very timely indeed. I'm sorry you can't see me on video. I don't know if you can unlock it remotely, but I can't it seems to be blocked at my end, but you might all be relieved that you can't actually see me, but I hope you can hear me well enough. I'll just say a few words about, oh, here we go. See if it works. No, it's not working, sorry. Anyway, I'll just say something about Global Action on Men's Health in case you haven't heard of us. We were launched in 2014 and we became a UK-based international charity in 2019. We've got over 50 organisational and individual members. And if anybody would like to find out more about how to join us and get involved in our work, please take a look at our website, which is www.gam.org. Our mission is very straightforward and nothing less than hugely ambitious. It's to create a world where all men and boys have the opportunity to achieve the best possible health and well-being wherever they live and whatever their backgrounds. And our main goal is to influence policy at the global and national levels. Next slide, please. What we did last month in response to the emerging crisis around COVID was to publish a call to action, which we did this for at the global level, but I think it's also applicable to the national level. And what I've done in the next 2 slides is to draw up a scorecard of how well I think the UK has done in meeting the calls to action that we set out last month. And I've used a traffic light system where red means doing badly, yellow means doing okay, and green means doing well. I'll go through the different calls to action that we made and say why I think the UK has done, how I think the UK has done in respect of each of them. Well, at the top of our list was a call for gender responsive actions at all levels, taking full account of the specific needs of men and boys, as well as women and girls during the pandemic and its aftermath. Well, that's a comprehensive call to action, really. It subsumes almost all the rest of the individual calls to action that we set out. And I think overall, when it comes to men and boys in particular, our view, and it'll be interesting to hear whether you agree, is that the UK government has done poorly in terms of meeting that goal. We haven't seen much gender responsive action. The one area where I think the UK has done better, and I've given it a green assessment, is in collecting and fast tracking publication of sex disaggregated data on the infection and mortality at all levels. When we did the last webinar, we didn't know very much. I certainly wouldn't have given them this score a couple of months ago, but since then, I think it's fair to say that there has been a lot of very useful data, and we now have a much better picture of how men and women are doing in relation to the disease. We also asked for data to be further disaggregated to show how outcomes by sex intersect with age, income, race, and other key variables. We now have quite a lot of that, but we still lack a complete picture. And we don't yet know, we can't see all the interrelationships between all of these different variables. We have some information, but it's not yet complete. We called for research to understand better the causes of men's high mortality and how it can be most effectively addressed, taking full account of the intersectional impacts. Well, obviously research takes time. Alan has outlined what perhaps the state of current thinking is, but there are still a lot of unanswered questions. And I don't think we can expect to fully understand exactly why men have done so badly for some time yet, until research studies have actually been completed and published. We have a fair idea of what the likely causes are, but we don't yet have a complete picture. Next slide, please. We asked for research into the wider impact of COVID-19 on the mental and physical health of men and boys, as well as on issues concerning their employment, education, personal relationships, and family life. Well, that research has begun. There's actually scarcely a day goes by when I don't get an invitation to participate in some kind of longitudinal research study around these issues. So I think it's fair to say that these studies are now ongoing and in the pipeline, but we haven't seen much data published yet. We called for the development and deployment of gender responsive health promotion interventions to reduce men's risk of infection, and evidence of good practice to be published. I'm not aware of if much, if any, action in this area. I haven't seen any gender responsive health promotion interventions from the government. I think the Men's Health Forum has had a go, commendably, but obviously its resources compared to that of the government are very limited. And we do need to see, I think, sustained action here, and it hasn't happened yet. We called for sustained support for organisations supporting men and boys, including for employment, education, mental health, alcohol and gambling, and also support for organisations working around domestic violence issues. And again, I think there's very little evidence that that's happened, certainly in terms of support for the voluntary sector organisations. My impression is that voluntary sector organisations have actually taken a huge hit in terms of their funding and their capacity, and are struggling to keep up with demand. And certainly we need more action in that area. And finally, we called for a focus on addressing the underlying conditions that are linked to men's high mortality from COVID-19, and which in their own right, and for a long time, have had a significant impact on men's health outcomes. And again, I haven't seen any attention paid to that. We know that the underlying conditions are a significant risk factor for serious COVID disease and higher mortality rates. And yet, I think we haven't seen much action or much discussion about action in the longer term to address those underlying conditions. Next slide, please. So what we did in our call for action, we said that COVID-19 has exposed deep, long-established and widely overlooked problems in men's health, and these must be tackled strategically and systematically by gender-responsive research, policies and practices. Next slide. And we are actually publishing a report, which Martin mentioned, comes out tomorrow. So please look out for that. You'll be able to find details on our website, and we'll be tweeting about it as well. We're publishing a report called From the Margins to the Mainstream. It's not about COVID specifically. It's about how we can actually get men's health issues onto the policy agenda at the global, national and local levels. And I think its publication is very timely in the context of COVID, because it just suggests what we might be able to do next to push COVID and men's issues further up the policy agenda. Next slide, please. So we produced this report because we know that men's health has been neglected historically, despite their obvious poor health outcomes, and that's very clear from COVID. COVID has highlighted the excess morbidity and mortality burden on men generally, and of course imposed its own additional burden. But despite all that, men have largely been absent from health policy at the global, national and local levels, and the policy barriers and opportunities and strategies for advocacy have not received significant attention. So our report tries to fill that gap. Next slide, please. So finally, just to suggest what the way forward is, these are some of the points that we highlight in the report, which I think have particular applicability to COVID. What we think could happen to push policy forward is we should collate and present the evidence. We've seen some of it today. We need to gather more of it and present a coherent case about why action is needed on this issue. I think we should formulate some focused demands. We should go beyond just saying that something needs to be done, and perhaps following the Global Action's call to action, we could formulate some specific demands, perhaps around research, a strategy for men, especially for Black and ethnic minority men, a focus on the underlying conditions, and calling for health promotion interventions, perhaps around hand washing, social distancing, and so on. And of course, we also need an intersectional approach in all of this. We can't just look at men as a homogenous group. We need to look at different communities of men and formulate strategies for each of them. We need to make sure that our policy is aligned with other policy if it's more likely to achieve traction and have an impact. And I think here perhaps we could focus on the underlying conditions like cardiovascular disease, diabetes and obesity, where there are already well-established health policy initiatives. And if we can ensure that men's issues are brought within those policies, we perhaps have much greater chance of success. And finally, I think we need to build alliances with other organisations. Men's organisations the men's sector is very small in the UK and around the world. And our ability to achieve success is likely to be enhanced if we can work in partnership with other organisations. And also we can add value to the work they do and bring new insights from our sector, which will inform and support their work. So I think working with other organisations on COVID and indeed the widest possible range of health issues is going to be extremely important for us. So thank you very much. I'll stop there and obviously come back into the discussion later if needed. Thank you very much.
Thank you very much indeed, Peter. And now it's a great pleasure to introduce Professor Gert Randhawa, who is Professor of Diversity and Public Health and Director of the Institute of Health Research at the University of Bedfordshire, and a trustee of the Race Equality Foundation. And I'd like to formally thank the Race Equality Foundation and the team there for helping us in getting this webinar together. It's much appreciated. So, Gurch, are you there? Is it all right?
Hi, Martin.
Good. Over to you, and on to the next slide, which people might recognise.
Thank you. So firstly, thank you to Martin and the Men's Health Forum for giving me this opportunity to participate. And thank you to Alan and Peter for doing such a fantastic job in presenting the evidence, the policy context, and some thoughts for the recommendations. I actually want to take a slightly different tack because I'm always wary of webinars and PowerPoints. So I will speak to this slide, but firstly, I just want to share really a story that I hope speaks to the slides that Alan and Peter have so well presented. And I guess what I want to share with you is a story, and hopefully this story will demonstrate to us all that disadvantage and inequality actually takes many forms. And through its many forms, it becomes a lived reality for different people in different ways. So this is a true story. It's a very short story. So imagine you've got a 20-year-old male. He's living in India. He's a farmer. He's the eldest sibling. He's in poverty. He has no formal education because he's always worked on the family farm. So just in that opening sentence, there are different levels of inequality. You know, being from a farming family, eldest sibling, poverty, no formal education. So his parents come up with a solution because they hear that, you know, the UK is wanting lots of workers and they want economic migrants, and they will take you even if you don't have skills. So the 20-year-old embarks on this adventurous journey in the 60s, arrives in England, has no skills, has no English, is a practicing Sikh, so wears a turban and a beard, so looks different. Finds out very quickly that if you're low skilled and don't have very good English, your employment opportunities are necessarily limited. And they tend to be limited at that time to steel foundry work, which means working with metals, being exposed to metal fumes, being exposed to limited health and safety, heavy lifting, but also, interestingly, on a personal level, means that at that time, to get the job, and because of the discrimination that was rife at that time, had to make the difficult but pragmatic decision to take off the turban, take off the beard, to fit in, and just reduce the discrimination. And we'll come back to this later. And then because he's got now a life to build in the UK, but also a family to support back in India, works 2 jobs, works 16 hours a day, 6-7 days a week. And as you can imagine, that has enormous mental health and physical toll when you do that level of work, and you take on as much overtime as you can. The modern day equivalent would be the 0-hour contracts. Through all of this additional work and heavy lifting, develops a lifelong back injury. Every time he goes to see the GP just prescribes him lots of sleeping pills. Sleeping pills are not helpful because that means he can't work, so doesn't really take them, so the back becomes progressively worse. Anyway, over the last, having done that for 20 odd years, the back finally caves in, can't really work. Modern day UK has evolved and become far more multicultural and receptive, so reverts back to being a practicing Sikh in his 50s. But lo and behold, didn't realise he has an unknown family history of heart problems, and sadly dies before reaching the age of 60, which in modern day world is a young age. And the irony being, even at the time of death, he still experiences inequality because he's a practicing Sikh. I don't know how many Sikhs are on the audience. As well as having the turban and beard, he has what we symbolically call the 5 Ks. When he dies, he died on his driveway, heart attack. He has next to him, we have a dagger, it's called a Gurban, which is on a shoulder strap. But because that's found next to him, the police, because they didn't internalize the cultural training they'd actually in fact been on, they thought this was a suspicious object rather than realizing it was a religious symbol. So even at the time of death, his family weren't allowed to go and see him in the morgue because it was being treated as a suspicious death. So even at death, he experienced inequality. And just in case you're wondering, that story is about my dad. And I just share that with you because I just wanted you to see that through his time, from not just in the UK, but in India, the disadvantage he experienced took many forms, and it is a lived reality. And just to emphasize, because my mother's still alive and I don't think she's listening in, I hope not. Her experiences are similar but also different. And all of these experiences are influenced by education, our economic opportunities, our access to health and discrimination. So now thinking about these recommendations on this slide, I think we have to be so careful when we think about trying to tackle inequality. Because I think when we talk about presenting evidence, I would be far more specific and say we need to talk about evidence relating to equity. And when we think about that, I would say that's why it's so important to think about types of evidence, but also making sure we have information systems that enable us to collect this data. So thinking specifically around COVID, what I'm interested by is there isn't really any granular data because really we should be able to compare data between diagnosis of COVID, between access to test, trace and isolate, between access to who's being risk assessed and who's not, between data to do with underlying conditions, and also, for example, within ethnic groups, as you've seen from Public Health England report, how all of these interrelate. And also there's question marks about issues, for example, like vitamin D. But we need this data to be publicly available. And I think this is one of the issues, is about, extracting this data has been a challenge. And I think if we start to, one, present the evidence and start to analyze the evidence and do it in a transparent way and a public way, it actually enables us to build trust with our public. And then if we think then about these issues around focused demands, well, I would be a bit more specific. I would say we need to be really specific about the tangible actions we require of government. And again, you will have probably heard this week that despite there being some very clear recommendations from Public Health England about what we should be doing to tackle the BAME issues, instead the government's response is to call for yet another inquiry. Now this is quite disappointing because for those of you who may not just have followed my work but followed anybody's work around ethnicity and health, you will know that most of the recommendations in the Public Health England report, they're not new. I mean, I wrote about 5 of those 7 recommendations, in fact, for the Race Equality Foundation back in 2007, where we talked about really taking an intersectional approach, making data available, having policy-based recommendations. So I think we've got to be far more assertive in our asks of government. And that's why I would wholeheartedly agree with Peter that if we take an intersectional approach and really start to understand the impact of age, gender, ethnicity, socioeconomic status, underlying health conditions, going back to the story I've shared with you about my father, that I think would really get us to understand, you know, it's a lot more than just ethnicity. There are so many other things that we need to think about. And this is what I talk about. It's the disadvantage that we need to tackle rather than just thinking about the discrimination of BAME communities. It's disadvantage that we need to tackle across all ethnic communities. And only if we all accept that are we going to make progress. I think policy alignment is an interesting term because the challenge is, and I say this having spent 12 years as a chairman in NHS, is policies and targets in the NHS may come as a surprise, hopefully not to many of this audience, is that many of the government targets and policies have no evidence base behind them or very little evidence base behind them. So it's quite difficult to align policy because most of our policy actually does arrive out of really sound evidence. So the work that Alan and Peter are describing, you know, is through lots of hard work that they've grafted on, others have grafted on. But when you then try and translate that into reality, that's very, very difficult. So I think what we have to think about is how do we ensure that we make these things tangible? So at the moment, there are no specific targets in the NHS about tackling inequalities. So I think we've got to find the appropriate pinch points when trying to deal with issues around gender, socioeconomic, or ethnic disadvantage, because these multiple disadvantages need to be tackled if we're really going to make this work. And I think I've shared in an interview for the Mental Health Forum, I'm an eternal optimist. I support a team called Wolverhampton Wanderers. So I actually want to finish on a high and talk about building alliances, because I want to share with you something about humility, but also about innovation. So a few months ago, some of you would have heard that there was this big, understandable debate and concern around PPE and about ensuring people were protected, and especially for FFP3 protection, which is the most sophisticated of masks. Rather than taking the humble approach and trying to learn and trying to consult with the public and maybe learn from clinicians, we just heard yet again this edict from government, oh, well, you know, if you've got beards, men, you'll just have to shave them off. And you saw lots of, you know, well-intentioned clinicians who just shaved off their beards. And that's no, you know, criticism of them. They did the right thing because they wanted to carry on looking after their patients. But one of my wonderful friends who is an amazing innovator, Rajinder Pal Singh at Manchester University Hospitals Trust, he's a truly humble man, but he's also a man who is willing to learn and he's willing to improve. So what he did was he thought, well, how do I, as a practicing Sikh, I have a turban and beard, how do I come up with a solution that enables me to solve this problem around PPE and still practice as a clinician? So what he did was he did build alliances, which is what we want people to do. So he liaised with the British Sikh Doctors Association, the Sikh Doctors and Dentists Associations. He reached out to the Sikh media. And a lot of this, this is hard work on his part because he's doing this in his own time. But the culmination of this is now, this is cited as an exemplar of good practice by NHS England, because they've come up with a culturally competent solution that enables men with beards to not have to shave off their beards while still practicing safely. So my final point really is, if we really do want to solve problems around inequality, I genuinely think we can. But it does mean that we have to be humble. It means that we want to genuinely work in collaboration. And I'm absolutely delighted, like I said, to have shared this amazing innovation that Rajinder Pal has championed. And please, if you're interested, go to the NHS England website and read about it, because it's now solving problems for men with beards and also for many people of faith. So the Muslim clinicians, Jewish clinicians, everybody's interested and everybody's working in collaboration to solve this. So thank you very much for your time and look forward to questions.
Right. Thank you very, very much indeed, Gurch, both for your academic and policy expertise, but also for the personal perspective that you gave. It was much appreciated. Right, we now have time for some questions. There are a few questions that have been raised through the Q&A and the chat, some of which we've typed answers to, but I suspect they're maybe sufficiently interesting that we may want to share them more widely. But there is one here from Hui Xiao. Men's health and COVID-19. What are the key outcome variables we should look at in terms of an intersectional approach? Would it be COVID disease severity or men's health related variables?
Can I come in on that one, Martin?
Sure.
Yeah. First of all, hi, Hui, from New Zealand. Something like 2, 3 o'clock in the morning. So extremely impressed that you've joined us for this this session. Key variables have to include age, ethnicity, socioeconomic circumstances, occupation, as you've been hearing. I think all of these factors are important. Once you get beyond that, it's harder to say that anything that we can get where we have a linkage. I mean, the sex disaggregation is one of the biggest problems we've been experiencing globally around sex and gender. And disease processes, but then when you have to link it to, well, so which of those men, what age are those men, what is their ethnicity, what is their socioeconomic status, what is their weight, what is their occupation? When you start to put all that together, then you start to see a much more nuanced picture. And I think that that's where we might well be able to start saying, right, so now we know where we have to do that risk assessment, now we know where to support people. Because until we do that, then we're always working blind. Good question. Thank you.
Anyone else want to provide some perspective on that? We've got a second. Well, there's a few questions I can quickly touch off that's useful for people to know. We've had several questions saying, are people okay for us to share these slides? Can people download and use information from our website? Yes, to both, essentially. We're very happy for people to share this around and get it in front of other people. Luke Newman has raised a question saying, I run a volunteer group called For Men to Talk. Frequent feedback of the attendees received is the lack of counselling after the typical working hours of Monday to Friday, 9 to 5. I'm worried this is an ongoing problem throughout the country. Do you agree?
Yes. For me, again, I've done a lot of work in Leeds. We've done a huge amount of work around trying to make the whole city gendered. We did the State of Men's Health Report. We've done the State of Women's Health Report. And we've been working very closely with the very vibrant third sector. And time again, what they say is they need to have support out there in the evenings and at weekends. And it's difficult to keep that going with the financial implications of that. But that's when men need need it. I mean, it's okay being told, oh, you can have an appointment at 9 a.m. 3 weeks time, but if you're suicidal or you need help, then it's less worthwhile. So I'm absolutely in support of any opportunities for men to get together, to talk, to be with other men, to be supportive, and actually it brings home how potentially damaging so much of this COVID lockdown has been, especially for older men who may be living alone, maybe living with a partner who's got dementia, maybe absolutely reliant on social groups such as the sheds, such as the gardening, such as theatre groups, whatever, to be able to give them some opportunity to meet up with other men. And so I'm absolutely sure that they must be struggling, even though many organizations have moved to use videos, moved to use telephones, but it's not the same as face-to-face.
Thank you. We have a few questions coming through in the chat. So G. Elsahim has written, Dr. Randhawa, what would be some practical applications of an intersectional approach, especially in workplaces?
Well, the most obvious starting point, thinking about COVID-19 is to ensure that all employees have risk assessments. So again, if you're following the media closely, you'll probably see that still many NHS organisations and care organisations have still been unable to offer their staff risk assessments, and this is despite it allegedly being a government priority, and specifically when they've been saying that, oh, we know that our non-white staff are at greater risk. So I think, in terms of intersectionality, we know that it's not just frontline staff, but it's people of particular age groups, particular ethnic groups. So I think this is, I think Peter's well-made point. It's all very well having the evidence, but if we don't then move that into action, it's actually, I think, worse, because we've now got the evidence. We know exactly what we need to do, and we need all employers to be offering all of their frontline staff. And I think, as I said, this is not even limited to health and care, retail. I'm sure many of you have seen the images, and many of you may have been out to the shops this week. There are varying levels of protection offered to retail staff, and I'm genuinely worried about that.
Thank you. Gert, I have another question for you from Bridget Bygrave, which is, given recent denials of systemic racism, what thoughts do you have about tackling disadvantage, discrimination and inequalities generally, and specifically for BAME men? Being assertive with government, ?
Well, I guess it's difficult because the government's own reports from Public Health England tells them that there is racism, there is discrimination. you've got the Royal College of Nursing, the British Medical Association, all producing survey after survey. You've got Runnymede Trust also showing this. And one of the things we do at the University of Bedfordshire in my institute is we take a life course approach. So we think about issues all the way from preconception to childhood, all the way to adulthood and end-of-life care. And you will see that at every point in life there are inequalities. And the government are well aware of this. So I think, on the one hand, having an inquiry is good because it shows it's on the radar. The problem is we've been here before. We've been here too often. And I think, I would want our various political parties to sort of really hold the government's feet to the fire to say the recommendations you've already been given from many previous reports, implement those before you embark on yet another inquiry.
So maybe there's a question from me that follows on to all of the other three people speaking, which is, what is going to be the way to get change on this? Is it that the men's health organisations put forward their wish list and race equality organisations put forward their wish list, and hopefully, obviously working in collaboration, we try and get them all implemented? Or do we need to find a more sort of systemic ask, maybe, which will lift all boats? Is it possible to do this through advocating sort of, I don't want to put it too strongly, competitive advocacy of all the different inequalities where everybody's sort of fighting for their particular needs to be taken into account? Or is there a different approach that needs to be taken? I don't know who wants to go first.
Could I have a go at that, Martin? Well, first of all, I wish I knew the answer, because if I did, we probably would have tried to implement some of this some time ago. But I think we certainly have to, as people who have got a particular interest in men's health, we have to beat the drum for men's health and try and make as much noise about that as possible. But we certainly can't do that in competition with other groups who are also have particular needs around this issue. There aren't binary choices to be made here. It's not men or women. It's not white people or black people. I mean, there are different groups here which have particular needs. But in a sense, we have to find a way of working together to make sure that the needs of all groups are met. But there is a kind of proportionate universalism, as it's been called, that the groups that have the greatest need have the greatest allocation of resources. And I think that's probably the way forward. So it's a combination both of collaborative work, alliance building, but also us emphasising as organisations working in the men's sector what the particular needs of men are.
Alan, Gurch, any reaction to Peter's comment?
I absolutely support the need for us to be lobbying. But as Peter says, we have to be mature about this, and we have to recognise that everyone is really struggling within this world we're living in, and it's about putting forward sensible solutions that can be immediately perhaps supportive at the moment, because we've got to be thinking about what's happening now. It's like getting kids back to school, whether it's a girl or a boy. We just need to get kids back to school. But then we need to be thinking about, in the long run, well, what's happening with boys' education? What's happening with men's higher risk of non-communicable diseases? What can we be doing to address the high risks that African Caribbean men have with regard to prostate cancer? There's a multitude of factors that still require us to hone down on some of the male-specific issues. But working in collaboration with others has to be the way forward. I've got some other questions as well that need answer. No, but Gurch.
Well, I'll pass on. Gurch, I think your turn or your response.
Yeah, I mean, I suppose, this is why I think, I'd go back to Peter's recommendation about evidence. During lockdown, I say this as a parent, but I'm sure lots of people are concerned. The physical health of children and mental health of children during lockdown needs to be, closely monitored. And again, I'm not convinced that the government are showing the level of concern and attention to this as they should be. So, I hope I'm not breaking any rules, but it's wonderful that, for example, Joe Wicks has put on this fantastic exercise program, but really government should have been thinking about, well, how are we going to keep kids healthy whilst they're at home? We know that obesity is linked to socioeconomic status and also impacts by gender and ethnicity. So the challenge for us is our health inequality is actually going to widen because of the lack of attention of these issues. And also, as we all probably aware from thinking about your own GP services, most GP services have moved to phone and video consultations. And a lot of the research I did a long time ago, when we used to have something called NHS Direct, we analysed about 15 million worth of calls, interactions for one calendar year. And we found that men were less able to articulate their needs and symptoms over the phone. So it was far better for them to actually pitch up in person, because they were then, if you like, forced to have to sort of share what they wanted to share. So I am genuinely concerned about the level of inequalities, and I think they will occur at many different levels. So I think where appropriate, the Men's Health Forum should raise them on behalf of men, but where appropriate, we should collaborate with other organisations like Race Equality Foundation and others to talk about inequalities per se.
I'd like to. We have another professor in as an attendee, Professor Frank Keating, who was a long-time friend of the forum, who had typed a comment, and I maybe bring him in to talk about his particular comment and provide some perspective on that answer as well. Frank, I'm switching on your microphone, or you can now, I think, switch on your microphone if you're still there. No? Has he gone?
Hello.
Oh, good, you were there.
Yeah, sorry, I got kicked out of the meeting. I don't know, and I just tried to get back in. Yes, thank you very much, Tom, and also thank you very much for Gert and Peter and Alan for the really very insightful presentations. And as I said in my comment here, even the report that came out from Public Health England and the recommendations that were blocked and only came out yesterday. The thing that I think is always missing in this is the lived experience of people. And I think, and when it comes to BAME communities, it's a cumulative lived experience. And Gert's example clearly illustrated that it's not something that's happened now. It's structural disadvantage is cumulative, and so any evidence should take that into account, and then any policy should also look at how we respond to cumulative the effects of cumulative effects of disadvantage. And that's what I wanted to say. Yeah, thank you.
Thank you very much indeed, Frank. I don't know if people have any response. We have a couple of other questions and comments to take. We have Emmanuel Turcot, is she still here? From Canada. I think anybody who gets up early to join a webinar should maybe have a chance to talk as well. So, Emmanuel, are you there to maybe make your point about the health network and the staffing of the health network? No, maybe not. I'll quickly read your point. In Quebec, Canada, the health network is largely made up of women. Is it the state seen elsewhere in the world, and how it affects the relationship of men with the health network? Maybe one for Alan.
We've seen a particular issue around gender as being representing women and not men and women. And I think that's something we have to work on. And it was very reassuring to see the World Health Organization for Europe do a men's health report. And the gender unit there is actively trying to work to enhance the health of men as well. But in many cases, health is still equated to women. Boys see their mothers. It's a perennial problem about how we get men to recognize health as a factor for them. And the lack of men within caring professions, the lack of men within schools, in infant schools, etc., as teachers, does have an impact. I'm sure it does, and the research suggests that it does. So I'm very cognizant, aware of the fact we need to improve the gender balance within many organisations, but not just the gender balance, but also the gender lens that the organisations use that recognise the significance of men's health. While I'm on, do you want me just to say something to Jamie about bladder? He had a question.
Please do. So
yeah,
if you want to restate.
I'm saying, very sorry to hear you're still having issues. It's good that you've come through it. This virus goes across the body. It has an impact in the digestive system, neurologically. It can get into the testes and orchitis. It can the ACE2, which we were talking about before, you might have missed, but is present within the bladder. There may be bladder issues. There may be all sorts of issues. Hopefully it'll settle down, but it's not, I don't think anyone coming forward with any problem at the moment wouldn't necessarily be able to say it might well be related to a COVID infection. There was another question from Jagdev about the rate of wet men in the older years, and he's absolutely right. Though that numerically there are more women, the rate of death in men, because there's numerically less number of men, the rate is still extremely high. And I think, I can't quote the figures, but I think actually the rate of death is still higher in men than in women, even though numerically we have many more women dying.
Can I just come in quickly, Martin, and follow up the question from Quebec?
Yes, please.
Great to see Emmanuel on the call.
Yeah.
Many people may not know that Quebec is the only city in the world that I'm aware of that actually has a men's health and wellbeing policy. And if Emmanuel was involved in that, I send my congratulations, because that is extremely important and significant. And I think the work that's been done in Quebec around men's health could be a model for other cities around the world to follow. But also, just on the point of women's involvement in health, I don't know if Emmanuel was alluding to this, but we know that some of the strongest proponents of men's health have been women. That was certainly true in the UK, where some of the certainly in the early days, some of the main activists in this field were women, and often nurses, and that was extremely significant. And I think that in terms of men's involvement in health, I don't think that's an issue. I think one of the questions that's often asked is, does it matter whether men see a male or female practitioner, for example? And the evidence suggests that most men aren't concerned about that. So I think, women's involvement in men's health has to be welcomed, and I think men also have to reciprocate and show a similar interest in women's health issues. And certainly in terms of women's involvement in leadership in health organisations, they're hugely underrepresented in senior positions, and that's something that, as activists in this field, we should try and do what we can to put right.
And I think that's, we're almost out of time now. I think that's a really good point to end on, because I think the one consensus that has clearly emerged is that while we will continue to have a role in understanding the particular needs of men and advocating for those needs, the most important thing we can do is be partners in a wider drive for tackling inequality, whether it's whether it's underrepresentation and lack of adequate health support for minority ethnic groups, by age, by deprivation. We need to be thinking that I think what I've got through from everybody is that needs to be a shared agenda. We're all in this together, and getting the system to be serious about a deep, a nuanced and complete picture of the deprivation and inequalities that people face, and to respond to that in an informed way will be critical to improving men's health. We are not going to improve men's health on our own. We will improve men's health by effectively tackling health inequality overall. You're shaking your head there, Gurch, or is that you agreeing or disagreeing? I thought I was trying to summarize the point there. Or are you shaking your head at something else?
I suppose the point I would make is we need some momentum about it.
Yes, absolutely. Momentum in terms of partnership, or just momentum? I think there is a point here, and certainly this is a conversation maybe that we have a follow-up conversation with the Race Equality Foundation. Never waste a good crisis. This is a great moment. We are in a moment where COVID has exposed the raw reality of health inequalities in this country and got it onto the front page. And I think this is the moment where we need to work in partnership with other equality organizations to say, look, this is real. You know, we are seeing the difference in terms of what happens in the deaths of tens of thousands of people. This is the moment you need to do something. And on that note, we have a couple of more slides. Firstly, Jim is on the call, but we have a lot of information on our website, information for men, COVID stories, COVID stats, COVID research, COVID campaigning, COVID donations, free COVID materials. We will also have a link to this webinar in full. COVID donations, we are a charity. If you know, all of these things that we're doing cost money. If you would like to make a contribution, it would be much appreciated. We will send around an email to everybody who attended with details of our WhatsApp group. I'm not expecting you to copy that link off the screen. And we have a WhatsApp about men and COVID-19. We also have an email list. The health information that we're putting on our website is something we are keeping up to date. In fact, I think we have it set up so that if you use the COVID-19 Toolbox Talk and we produce an updated version, it will be sent through to you automatically. So please do go take a look at that, as well as the latest research. And as we've talked about, now is the moment when we need to work in partnership with others to get serious action to tackle health inequalities. Here are our contact details. We will be sending around the slides. I know all of our speakers are happy to be contacted by you. Thank you to everybody who's attended. I think we had a peak over 150 people here. That's greatly appreciated. Feel free to send in any further questions you might have, and we'll do what we can to answer them. But thank you very much indeed for attending.
Thank you.
Thank you.